This conference will now be recorded.
And so today we are joined by Michelle Madison of Morris, Manning, and Martin, who will give a review of the recent ruling by CMS regarding the requirement for hospitals to publish pricing before actually providing services. We've had a lot of questions from folks with a variety of questions, lots of concerns, and just basically needing some clarification. And so with that, let's go ahead and hand it over to Michelle to get us started. Michelle?
Thanks, Jason. Hello, everyone. It's great to talk to you today. We're going to go through the requirements of the price transparency directly from the regs, and then as I'm talking through that, I'm also going to talk about the American Hospital Association lawsuit where they did sue the Secretary of the Department of Health and Human Services related to this case, and there was a ruling at the district court level in June where they actually sided with DHHS. I'm going to talk a little bit about that as we go through this. That case has now been appealed to the appeals court for the district, so we are waiting to see how that will ultimately pan out. But as of right now, our deadline for being in compliance is January 1st, and there's a lot to be done, so we really do have to continue to work on this as we move forward. And when you read the opinion from the court, you can tell just by the words that they were using in the opinion that we just need to move forward and get ready, because it looks like they really are deferring to giving great discretion to the Department of Health and Human Services on this arena. So let's go to the next slide, Jason. So just to give a little bit of background, this actually all started with the Affordable Care Act, where they required for hospitals to list our standard charges for items and services. So you all remember we went ahead and published our charge masters that were out there. And the concept of the Affordable Care Act was to make transparency predominantly with the consumer about what does it cost for you to get care. And remember, Affordable Care Act had all those provisions about everybody having to have insurance. And so following the Affordable Care Act, the CMS rules in November of 19 kind of identified what standard charges are. And then the president gave an executive order June 24th of 2019, which the timing is very interesting because it was 1 year later that the district court upheld it. And that was a couple of different things included in the executive order, all of which came off of Affordable Care Act. So requires the hospitals to publicly post standard charge information. And that's related to not only here's our charge master, but here are the negotiated rates that we have for certain types of services. And in a few minutes, I'm going to talk in detail about they are requiring us to publish data about 300 what they call shoppable services. And there are 70 services that CMS has said, these are 70 that we expect you to include. And if you don't actually provide these services, you need to document that you don't provide these services. And I'm going to talk in detail about that in a few minutes. They also want to make sure that it's easy to read. So based upon the format, that it's easy for someone to access it and see it. If you all remember when we did the Charge Master publication originally, a lot of us put that on our pages where we have financial assistance programs for patients, so they understand this is our entire link on our website that deals with what your financial responsibility is, and here are all the programs we have to help you. Sometimes that was easy to find, sometimes not so easy, so we're going to talk about that today as well. Those standard charges also have to include the supplies, and we can go to the next slide, Jason. And the big part was to make sure that we were providing access to information so that somebody could figure out what's their out-of-pocket expense. So are we in network, are we out of network? Obviously, we're not talking about this today, but the surprise billing laws also play into this. And so making it transparent for somebody who says, hey, I want to go have my knee done, and how much is that going to cost me if I go to hospital A versus how much is that going to cost me if I go to hospital B, and what are the rates based upon my payer and what's my out-of-pocket expense? A lot of information. And if you just look at what we do on a day-to-day basis in the hospitals, we have to go calculate that information and try to figure it out based on our contracts and what's the patient's copay and deductible and how much are they paid already. It's incredibly difficult and complicated. So this directive for us to comply with, I feel like, is difficult and very resource intensive. So I do want us to talk through this today. Let's go to the next slide, please. Some of the slides that I have here will specifically cite to the rules. And so what the rule requires is for us to publish our standard charges for items and services. And I've got a couple of slides in here that really define what these terms mean under the final rule so that you'll know when you look at them, okay, this is what I'm focused on. And the concept is to make it easier for patients to shop, to say hospital A versus hospital B, what's my cost, what's my out-of-pocket expense, where are their charges and where do they fall. Let's go to the next slide, please. All right, so we have to display shoppable services, love that term, in a way where we say, okay, this is what our negotiated charges are, this is what our charge master is, and it's a couple of different charges. You're going to hear me say this a couple of times today. There are 5 different types of charges that we have to publish. One is just our straight, here's our charge master, this is our gross charge rate. The other is, here is our discounted rate. Then the other is negotiated payer agreement rate for each payer, which makes it incredibly difficult. And then there is the de-identified minimum and the de-identified maximum rate. So for my knee to be replaced, let's say we've negotiated the lowest rate with Cigna, and let's say we've negotiated the highest rate with the Blues. And so I'm going to de-identify that and not identify the payer, but I'm going to list my minimum and my maximum on that service line. So all of that has to be published in a way that is consumer friendly. That's a difficult term, that's obviously ambiguous. It also has to have a description of the service. So remember when we did our charge master, some of us have just the CPT code and then a small description and then the charge because we just downloaded it. The problem now is you need to go in and make sure that description would actually be in plain language for someone to understand. So plain language meaning knee replacement versus the medical term for replacing a knee. So making sure that we have that in a format that is readily available to our consumers on our website by January 1st. Let's go to the next slide, please. The hospitals, so some people have said, well, maybe it doesn't apply to us because one of the areas that they do focus on is the DRG. And so the critical access hospitals have said, oh, well, this doesn't apply to us. Unfortunately, it applies to any hospital that's in the United States, with the exception of the government organized hospitals like the VA. They have said that the VA has a captured group of patients, and so they don't necessarily have to comply with these requirements, but they did not differentiate between a hospital that's licensed as critical access or PPS. So we all are in the same boat together. Let's go to the next slide, please. And we have to look at our items and services. So what's our supplies? What procedures do we do? What's our room and board? What kind of facility fees do we have? Services of our physicians if they're employed, and other services. So I'm going to take a second here and talk about the types of things that CMS has said you have to have this out there. And if you don't render these types of services, then you're going to have to notify us in that format that you don't have these services. So they put it in a couple of different buckets. For CMS, they said there are 70 services that you have to have in your list. Evaluation and management services, they include 13 different services, and they have identified them in their plain language as psychotherapy, and so it would be 30-minute visit, psychotherapy 45 minutes, psychotherapy 60 minutes, and it has the CPT code. And then family psychotherapy, again, based upon the different levels, group psychotherapy. And then your new patient visit in the office, outpatient visit, patient consultations, and new patient preventative medical evaluation visits. And there's 2 different codes for that. So there are 13 evaluation and management codes. If you don't have providers on your hospital staff that do psychotherapy, you would list this in your 70, but then out to the side, you would say, we do not provide this service. Now, the other buckets of services under the 70 different listings includes laboratory and pathology services, radiology services, so your CTs, MRIs, X-rays, all of those, mammography, ultrasound, medicine and surgery services, so cardiac valve, spinal fusion, major joint replacement, cervical spine fusion. And we've got a list of these, and I'll make sure that you guys have access to them as you need them. But those procedures go all the way from cardiac procedures down to sleep studies and physical therapy. So those 70 procedures, we should literally take those descriptions from CMS, put them in the chart in a readily viewable format And then we have to put our 5 different types of charges for them. Our payer negotiated ones, our gross charges, our discounted charges, our minimum and our maximum. And so let's go to the next slide for a second. So within those 70, the list of the 70, that includes your supplies and some of those different items that are items and services we have to list. It has to be in a machine readable format, which means the data can be imported or read by a computer system. So they consider, obviously, Excel spreadsheets, the CSV formats, that's the formats we usually see the banks use. That type of format would be a digital representation. Payer-specific negotiated charges is a charge that the hospital has negotiated with a third-party payer. So do you have a third-party payer agreement with this entity? And is there a fee-for-service exhibit that you have that lists all of your services and what that fee schedule is? Or is it more like a percentage of charges, and so then you can do a formula to calculate your percentage of charge for that payer? This is one of the reasons why I'm worried about us starting earlier than later, is that January 1st, 2021 is the deadline right now. And the way the court came down with the district court decision, I think we should all focus on that staying the deadline for right now. And my concern is that pulling all of these different managed care contracts and looking at our payer rates and then looking at these different codes, especially the 70 that CMS has identified, to figure out what we get paid from the managed care contract, that's going to take some significant time and resources. So I do want to make sure that we have a team and you've got the right players on the team to make sure we're pulling the data right now, at least for those 70, and then I'm going to talk about the other 230 services in just a second. But making sure we've got all that information and can readily produce it in a format that not only can we produce it on January 1st, but that we can produce it and update it from time to time, because one of the rules is we have to update this at least annually. So that's the payer-specific negotiated charge that I'm concerned about. And in the American Hospital Association lawsuit against CHHS, they did talk about the fact that it did not make any sense that we would be publishing that kind of data because it's trade secret data and it's information that we would have in a contract that we have negotiated that should remain proprietary. And the court did not give any weight really to that argument and ultimately said that the congressional goal of trying to make sure that patients knew what the actual charge and out-of-pocket expense would be required the publication of this type of data. And they went further in the opinion to say that the patients will get an explanation of benefits. And so they already know in that explanation of benefits what our reimbursement rate is. What was interesting is, as I was reading the opinion, my thought in my mind was, well, not everybody in the world knows what that EOB says, just that patient. But they took that to the step to say that that's public information because it was published on the EOB. It was an interesting way of addressing the trade secret argument. And again, this is on appeal, so the appeals court may come back and say this really is proprietary, confidential information that is strategic in nature to hospitals and helps us to be able to be more competitive. They think that publishing the data will make it more competitive because we'll be negotiating with a full knowledge of what's out there. But it'll be interesting to see where the appeals court goes with this. And then now, so that's on the payer-specific data. On service package, in the rule, they talk about the fact that a lot of hospitals, specifically PPS hospitals, get paid based on a DRG. And so there's supplies and facility fees and items and services that all get bundled into that one payment based upon the diagnosis code for that patient. And so they also recognize that the hospitals, when they negotiate with third-party payers, sometimes we negotiate based on DRGs as well. So we'll list on our fee schedule, DRGs are going to be reimbursed at X level, and here's the DRG code that we assign to it. And it may not be a Medicare contract, obviously, it's going to be a third-party payer contract. And so that's where they call it a service package, where we bundle the services related to that DRG into one service package. So it's the aggregation of those. And so we are required to include those in our 230 additional services that we provide. Let's go to the next slide, please. So as we're talking through this, there's 5 different types of charges that we have to list. We have to list 300 shoppable services, 70 of which CMS has given us. And again, just to remind everybody, They fall into evaluation and management services, radiology services, medical and surgical services, and laboratory and pathology services. Those are the buckets. And there are between, some of them have 13, some of them have 20 different procedures under each bucket. But for each one of those, we have to have a description of the service in plain language so anybody can read it and understand what that service is. And then there has to be a gross charge. That's our charge master. That is, when we go and we send out a claim, this is the charge that's going to be on the bill. So that's the gross charge part. Let's go to the next slide. The next charge is the payer-specific negotiated charge. So that's for each item or service that we have on this list. We have to list out in the hospital inpatient setting, in the outpatient setting, what our negotiated rate was. So if we have a contract with the Blues and it says under radiology services, we're going to pay you 85% of your charge, we have to calculate that and put that out next to each one of those radiology services, which again, out of the 70, there are about 12 that are radiology: CT, MRI, X-ray, abdominal ultrasound, mammography, and the 3 different types of mammography. So in that instance, we would list in the hospital inpatient setting, if it's not bundled together as a service package or a DRG, then we would unbundle it and show them what those rates are. But if it's on the inpatient side, it's part of the service package, then we would list it in the service package. On the outpatient side, again, we would list that for each payer that we negotiated a rate with. If we did a fee for service and we said, all right, every mammography is going to be $23, then we have to put that on the list, $23 for United. Let's say we negotiated that with United. As that updates, so let's assume for just a second for fun that and this is for fun, our United contract has a 10% increase every year. Wouldn't that be nice? Then every year we'd have to make sure we updated it to show that 10% increase on that reimbursement for that radiology service. The next one that we would put on this list would be the de-identified minimum negotiated charge. So that's where we say, all right, Blues through Cigna, or the Blues through whoever, we have negotiated the lowest rate with this one. We don't list their name, we just list the rate related to that service. And then the same concept on the de-identified maximum. So that would also be there. The other one that we would list on this chart would be the discounted cash price. So these are our patients who do not have insurance or have elected not to use their insurance. And so they're going to be our cash pay patients. And in that instance, we would list out based upon our financial assistance policies, not our charity care policies, but just the cash pay discount policy. So some of us have the same policy for self-pay discount and for charity care and indigent care. It excludes indigent and charity care and really is just focused on our financial assistance policy for our cash pay patients. According to this court case, they argued that about 90% of the patients that come to our hospitals have a negotiated rate through a managed care insurance provider, which I thought was interesting. That seemed higher to me than I actually thought was out there. But their argument was that really 90% of the patients that come have a negotiated specific rate from the managed care company. The American Hospital Association has been arguing in these cases that each one of those rates differ based upon the specific payer, and that our standard charge, because that's the definition under the rule, should just be our charge master alone, and we shouldn't have to do these 5 other different charges. But as they did that argument, the court really broke down and said, when you look at what percentage of people actually use managed care, they said 90% of hospital patients rely on third-party payer agreements, which really leaves about 10% falling into this discounted cash price bucket. Again, that seems lower to me than I thought on the 10% discounted cash price. And then any other code that we use, from a HCPCS to CPT code to DRG codes, that also has to be published as one of the data elements. So just to recap for a second, because I've talked about the case in the middle of these 2 slides, we are going to list out for the 300 shoppable services, our gross charge, which is charge master. Then we're going to list out our payer-specific negotiated charge for each one of our payers. We're going to list out the de-identified minimum negotiated charge. We're going to list out the de-identified maximum rate of charge. and we're going to list out the discounted cash price that applies to our cash discount when someone is a cash pay patient only. Let's go to the next slide. And then this is talking about, all right, we're going to list out these different charges. Those are data elements along with the CPT code or the DRG code that applies to them, or the HCPCS code. And then we've got to make sure we've got the 70 CMS ones that are on there. And then we have to pick an additional 230. So this is another area where this work team really needs to decide what are the additional 230. So what they want us to consider is the rate that we provide those shoppable services. So if I'm looking at my decision support tools in the hospital, I'm going to run a report on what codes do we bill the most related to items and services and bundled services. And then I'm going to pick the ones that fall in the top. And so when you do that, you're going to have some of the 70 that CMS already requires. And so then you got to move yourself down until you get to a total of 300. If within the 70, you don't provide some of those services, then you might have to, you're going to have to provide a total of 300 services. So you'll be putting more services out there on your list. The hospital must make public information for as many shoppable services as provided. So if you don't do 300 services, and let's say you only have an offering of 200 services, you have to list all 200. You also have to make sure that if you want to meet these requirements, one option is that you can use an estimator tool. So in other words, instead of me having this massive document out there that's got 5 different listings of different charges for each one of these 300 shoppable services, I'm going instead to use an estimator tool so that patients can go in and say, I'm a Blue Cross Blue Shield patient, this is the kind of service I'm going to get, what's my out of pocket? But it has to meet these requirements. It's got to provide the estimate for as many of those 70 shoppable services that you provide, number one. Number two, it's got to be able to make sure that it's got the additional 230 shoppable services for a combined total of 300. So if you don't do some of the 70, make sure you add more on the other side. And they have to be able to, when they go in to use the tool, get an estimate. And we can't charge the patients to use this. I have a slide in a few minutes about that. And then you also have to make sure that it's prominently displayed on the website without having them enter their information and give you identifiable information for the purposes of using it. So it's got to be a tool that can be readily accessible by anybody, and I can just go in, type in the information, and get it without you actually knowing who I am asking for that information. Let's go to the next slide. So the estimator tool, we've talked about that. The other data elements related to the listing, we've already talked about a little bit, but this is just for your records. Making sure it's in plain language, making sure the indicator says exactly what you're dealing with. Let's go to the next slide. This slide on the data elements also includes the language that's directly out of the code, which we've already covered. So we can go to the next slide, please. All right, the location. So they want it to be prominently displayed. I think you really got to sit down as a hospital and think through, where did I put the other information? I've been to some websites where I spent maybe 45 minutes and I never did find the charge master list because it was somewhere, but probably located on a financial assistance page that I could not locate just coming off the main page of the facility. So it needs to be prominently identified in this instance. So it may be that you create a financial assistance page that has your gross charges of the charge master, it has your financial assistance policies, it has your cash pay discount, and it has an estimator tool or a link to where people can find the information related to these different services. But it does need to be available. Let's go to the next slide, please. Now I talked a little bit about this, and let me just say the last 4 slides are directly from the rules. So the location, that's the language in the rule. This language is also from the rule. It has to be accessible, and I mentioned free of charge. So I should be able to go to any hospital's website on January the 3rd, 2021, and enter DRG code 470 if it's a PPS hospital, and be able to find out if I have Cigna, what my Cigna reimbursement rate is if the hospital is a participating provider in Cigna. And I shouldn't have to enter my information or give you identifiable information in order to access it. I should be able to search for it by description, code, or payer. The other part is, remember, a lot of us, when we have marketing materials, let's say we have education material out on our website and we have, oh, you can click on this to see the video of Dr. So-and-so telling us about cardiac caths and the benefits of such a procedure. And when we use that for marketing purposes, a lot of times when you click on the link, you have to enter your name so that the hospitals are capturing the names of who's actually using their information. And so from that standpoint here, we can't do that. We can't use this as a marketing tool. We can't capture that patient's information. It has to be free of charge without having to register. And then we also have to make sure it's updated at least annually. Let's go to the next slide. So what happens if we say, you know what, that lawsuit's pending out there, American Hospital Association has appealed it, we're going to wait and see what the appeals court does, and we're just not going to worry about January 1st. So what happens? The court had said that CMS and the Department of Health and Human Services does have the discretion to enforce penalties here. And so there's a couple of processes they'll go through. It won't be automatic, but the penalty could go up to $300 per day for every day you're not in compliance. But the way this is going to work is they will go and look at websites and they will determine, can I find it? Is it prominently displayed? Can I get to it without entering my own information? Does it list the 300 shoppable services? Can I search it easy enough that there's a plain description of that service? And if they determine that it's not accessible, then they will send us a letter saying, we've determined you don't satisfy the requirements of the price transparency rule, and here are the areas that you are deficient. And they may offer you an opportunity to cure that deficiency, especially in the beginning. And then if after that, they can assign penalties. So it'll be a process where we will get notice and then they could assign penalties. And it may be a notice like we couldn't find it on your website at all, in which case they may jump to, we're going to assess a penalty unless this is done. So there is a process and there are penalties associated with it. The American Hospital Association argued in the case that DHHS did not have the authority through CMS to provide penalties under this rule. And they basically, the court was, I don't want to say sarcastic, but the words that they used when they responded to that argument clearly provided evidence that they deferred that the way the law was written, and they even acknowledged that it was an odd place that the rule was put in. But if you look at the regulatory language, there are about 6 different subsections to the rule, and then in the middle of those subsections is where they granted CMS the authority to sanction individuals who don't comply with this rule. And it seems out of place where it is in the regulatory references. And the court acknowledges it seems out of place, but it is there in black and white where it says they can sanction. So they upheld the ability of CMS to sanction hospitals for not complying with this rule. So that is an area where we know that if we're not in compliance, then we are going to potentially be subject to fines and penalties. And at first you think, oh, $300 a day, fine, we'll deal with it. But that can add up pretty darn quickly, because think about how much information you actually have to pull together. If you haven't done any of it and you're out of compliance January 1 and the rule doesn't change, it's 300 days for every day while you're trying to get into compliance. And I do think this will take an extended period of time to pull the data for each one of these code sections. Let me go to the next slide. I've included in these next 2 slides what the court defined and what they cited when they talked about these different charges, because you do need to make sure you've got all 5. So the gross charge, that's your charge master, absent all discounts. Discounted cash price, the charge that applies to an individual who pays cash and not your charity care or bill forgiveness policy. So remember, look at your cash pay policies. We may need to separate out your cash pay discount policy from your sick and your indigent policies. Let's go to the next slide, please. The other is the payer specific negotiated. That's what you've negotiated with third-party payers. And then your de-identified minimums and maximums. So those are the charges that they referenced in the rule. And those are the charges that the court said, these are considered standard charges. And they believe that the definition of standard charges includes every one of these subsections. And they went through a lot in the order from the district court to go through why they believe CMS used reasonable discretion in defining standard charges the way that they did. And the reason for that is they feel like hospital billing is so complex and it's so difficult to understand what our bills are for and how our claims are processed, that breaking it down into these different subsections so it's more applicable to the buckets of patients that we have was more appropriate and was a better tool for transparency. And what they said was the role of price transparency from a congressional standpoint, they're using price transparency to bring down healthcare costs. And they believe that us publishing that these charges will bring down healthcare costs because it'll be transparent to everybody of what we're getting paid. And they think it'll make it clearer for patients how the billing process works. Now, there are other arguments against that, that obviously it could hurt the hospitals and it could actually become less of a competitive benefit for hospitals because everyone will know what the charges are and what you've negotiated with third-party payers. So there seems to be a missing component there related to FTC and competition, but that is where the court came down in that ruling in June. So while the appeal is processing and we're waiting for the appeal, the next steps that we should take is to focus on the charges and get the data together. We can go to the next slide. I think I'd like for Jason or Mike to talk a little bit about, I've talked about the charges and all the data that we've got to pull together to be in compliance with this rule. But there is this alternative where you can use an estimator on your website so the patients can go in and list the payer, the code, and they can get the rate and their out-of-pocket cost. And if you all can talk to the pros and cons of that tool, as some people are trying to figure out, do I really want to list all this out in this big format, or is it better to get a tool? So I'll stop there.
Yeah, Michelle, this is Mike. I guess the issue really kind of comes back to, as you listen to this whole thing, it's a balance between the fact that if, one of the hospitals on the phone absolutely knew that the only people that would ever access that information are people shopping for care, then the broadest, most helpful version of it that you could possibly put out there would probably be helpful to you, not just as a public service, but also as a marketing tool, et cetera, before it was all said and done. The fear and the concern that I think everybody on the phone really shares is who's really going to be accessing it. And it is all this information that's going to ultimately hit the web. Is it really for patient usage or is it for payer usage? Is this a service item out there, or is this a painful transparency for the payers showing each other what they're paying you guys, that what's going to happen under this, such that when we start thinking about the estimator tools that are out there, I think there's tremendous pros and cons. This is not an indictment of one. This is certainly, and there are more than one of these tools. They're in the recent weeks, you've seen they're sort of coming out of the woodwork, and there's several that have been knocking on hospital doors. You guys have probably seen one or multiple ones, or even had tools like Quadex that you were already using internally for this that could be turned around and kind of pointed externally to provide this kind of stuff. And so as you look at those, our only thought, or our kind of pros and cons thoughts, are that the pro of using a tool is that, well, we don't have to have this explicit list that gets shown out there with all the payer information individually that is listed for the 300 services that hit. The next point, for the full list posted, you don't have to just show the list. It wouldn't be possible really for somebody to download in mass the entire list from the estimator tool in the first place. If somebody's going to use it, they're going to have to go in and pick out pieces of it to use. And then obviously, like I was saying before, from a patient consumer perspective, it is a service if it's an easy enough and easy enough to find, and they should be able to find some information on their needed care and the cost of it, et cetera, for you, and that would be a pro. The con, on the other hand, is that the hospital's got to build the tool, or at least buy a tool and populate it with the full list of services rather than the 300 for the payers and behind the scenes, so that it's going to be completely interactive. Then the next one, the patients won't necessarily see how their insurance compares to others. They're going to pick out their number. It's not going to be a comparison to others. So they'll see, how Humana pays, not how it shows against others, to give them if you have a plan in town that you'd rather point to somebody toward, It won't show that kind of information. And then likely we're looking at the ongoing cost to maintain, build on the website, buy the tool in the first place if you're outsourcing it, which seems like a much more reasonable option than trying to build your own tool, versus just publishing it one time and updating it periodically as an Excel document. So I don't think, again, not for it or against it per se, but I do think it's eyes wide open that it is the balance between providing a good information about services to the local community, balanced with the fact that we may be putting information on the web regarding our negotiated rates that payers can use against us. And just like the stated purpose of it that Michelle talked about, if the intention of price transparency is to make all the rural hospitals show their prices, or all hospitals show their prices such that the shopping of it will drive patient selection, well, then there becomes a value to be Walmart. And does that put us on this cycle of downward pricing that can be painful if you're, in the middle of rural Georgia? So that's really it, and certainly we're glad to talk offline about it. Michelle, I guess the next one was the disclaimer.
Yeah, so those are our slides for today, and more so just as a resource for you in relation to what the pool is. And I don't disagree. I think first of all, if I was a hospital, I would have a team set up to include my revenue cycle management, my IT department, and my managed care contracting group to go through and determine, should we do the estimator tool? There's pros and cons to that, or should we do this listing? I worry about the listing for all those reasons that you just talked about. But at the end of the day, when you read the court's decision, as much as I think some of the arguments that they made were not, could be refuted, let's put it that way. The way they took their stance made it very clear that they were siding with DHHS. So I think we should not lose sight of that January 1st deadline, because I really don't see that going away right now, sitting here. Unless the appeals court turns something around quick, I don't see that going away right now. So that's what we have for today. I think we have a couple of questions. One is related to the identification of payers that are not contracted. So these are just payer-specific negotiated rates. So if you haven't negotiated those rates, I would not list out those rates on if you're listing out payer-specific rates, it specifically says payer-specific negotiated rate in the rule. And then for the other question was whether or not you need to include, if your hospital owns a physician practice, but it bills separately under a separate TIN, do those charges and contracts need to be published? So that's where I think you've got to look and see if your physician practices are hospital-based. If they're under a separate TIN, they're not hospital-based. And I'll confirm this, but I don't think we have to list those. It's only, they do have under the definitions items and services of employed physicians and non-physician practitioners as professional charges. But my question would be, have we negotiated those for purposes of the services rendered in the hospital? And in that instance, it may fall within one of your shoppable services, but I'll confirm that and send you back a written response.
So, Michelle, kind of tangential question. I see that we have some of our physician practices on the phone today. First, the intention of the rule is to apply to hospitals only for right now. True?
Yes, that's the definition. It's hospitals only.
And then the secondary question, if I was one of them, I would be asking, are we leading on a path to where something similar might be required for physician practices, ASCs, imaging centers, et cetera, in the future?
So this is totally speculative, but remember hospital compare, and then we had physician compare. So my answer to your question is yes, because it is typically progressed into these other sites of service. They start with the hospital and they go from there. And remember, the whole method of healthcare reform, which is where this started, was to have prices and reimbursement decrease, focusing on quality outcomes and moving patients to the site of service where it's the least expensive, highest quality outcome for the patient. So they've been pushing us to ASCs and pushing us into other sites of service outside of the hospital. So I anticipate all these rules that they put on the hospital side will dovetail over into these other sites of service.
Gotcha. if there aren't any other questions, thank you, Michelle. I really appreciate it. Why don't we push down to the super quick COVID update and we'll get you off the phone. Really only two things to share. One, from the Medicare prepayment perspective, the recoupments have been, the CMS director officially put them on hold and waiting on the congressional direction for that, or executive order direction for that. And so again, we've been saying we don't expect anything to happen until after the general election. I think that's kind of official now. And so those are on hold for right now. We'll certainly update you if you hear anything different. And then y'all would have to be kind of under a rock to not have seen that the HHS reporting requirements came out. There's a lot of detail about that we need to walk through in a couple of weeks, which we will do with you. But if you have a chance, you probably need to be reading through it. We have some, we were kind of hoping for a little bit more open-ended version of a lost revenue calculation that seems to have some limitation to it. There's also a category to retention of capacity that we need to look at in some detail to see if maybe there's some opportunities in that, especially on the hospital side, as you kind of think about your capital budgets and the things like that that could have been, that are sort of related to, you know, imminently retaining capacity to provide services. And so if you flip to that last slide, we'll be walking through it in detail on October 14th from 12 to 1. That's for practices and hospitals, and kind of giving our take on it. Any other questions for everybody this morning? Michelle, anything else?
No, just thank you for having me today.
Thank you. I appreciate everybody. Y'all have a great day, rest of week. Thanks, Michelle.
Sure. Bye.